Good evening, everyone. It's so wonderful to see you all here today. Thank you so much for coming out. Today we're all here because we all have some connection to, interest in, or some other relationship with lung cancer. I know many of you in the audience, and it's really so fantastic to have you here. We don't have a Zoom component, so we don't have virtual people listening in, but we are recording this so that you all can watch it again if you just thought it was so fantastic. You want to see it a second time around, or of course, other people can watch it later on. So I'm Sarah Goldberg, for those of you who don't know me. I'm one of the co-directors for the Center for Thoracic Cancers here at Yale. I'm a medical oncologist. I've been here for almost 14 years. We've done this program for many years now, and I think it's probably one of the highlights of the year for many of us. I think it's just so special to be able to see all of you in this setting, and to share the excitement that we have over what's been happening in research for lung cancer and in the advances in so many ways, and to be able to show you what we work on kind of behind the scenes when we're not in the office with you all. We do a lot of work here, and lots of other places do too, to try to make lung cancer better, to try to understand it better, to try to figure out better treatments and better ways to take care of our patients and their families. So we're really excited to be able to share all of that with you. I wanted to introduce two other people. One person is standing right next to me. This is Dr. Katerina Politi. She is a cancer biologist. We work very closely together in all those behind the scenes things, so trying to understand lung cancer better and figure out better treatments. Katie is the scientific director for the Center for Thoracic Cancers, and you're going to hear from her in a minute. I will also introduce someone who's not here right now, but he will be shortly, Dr. Justin Blasberg. He's a thoracic surgeon, another one of the directors of the center. And again, we all work together to take better care of our patients and to advance our scientific mission, help educate our trainees, and do all sorts of things to make things better for this disease. So look at my notes to make sure I'm not missing anything. I think that was all that I was supposed to say. I will just briefly show you what we're going to be talking about this evening. This is our agenda. You might have seen it hanging up on the walls in the clinic or gotten an email to you. Our goal is to focus on exactly what this title is, progress and hope, to show you how far we've come and what we're hoping for in the future. And so we will be first hearing from Dr. Roy Herbst. Katie's going to introduce him, so I won't go into details, but he's going to, I think, give you a great talk. Unfortunately, he's not here tonight, but he's going to join us virtually. Then a lot of people last year told me they wanted to hear more about what's coming next. What are the really exciting drugs coming? And so we're going to take a little bit of a closer look at some emerging therapies, and we have some great speakers there to get you excited about what's coming in the next couple of years, what's in trials now. And then we always think it's so important to talk about screening, lung cancer screening, because as the title says, early detection saves lives. So we're going to have a panel about that. You'll hear from some people about that. I'll moderate a panel on lung cancer clinical trials and why they're so important in our progress. And then we're going to talk about bridging expertise. So bringing it all together, all the different disciplines and people that help to take care of people who have lung cancer in their families. So you'll hear from lots of different people about that. So I think that was all I wanted to say. I will turn it over to Katie to say hello and introduce our first speaker. Thank you all so much again for being here.
Thank you very much, Sarah. It really is a pleasure to be here tonight, and thank you very much to all of you for coming and participating in this event. Before I introduce our first speaker, I'd really like to thank Emily Montemerlo and Renee Gaudet, who helped put this together, and everybody who's also outside at the tables to give you information on lung cancer screening, smoking cessation. So thank you to everybody. So it really is my pleasure to introduce our first speaker, who's going to be speaking virtually. Dr. Roy Herbst is the Deputy Director at the Yale Cancer Center. He's an Ensign Professor of Medicine and the Chief of Medical Oncology and Hematology here. Dr. Herbst is a pioneer in lung cancer care and treatment and really has advanced our knowledge of lung cancer over the years, running clinical trials, innovative science, and really leading the field. And we're so lucky that he's been here at the Yale Cancer Center for many years, and all have had the opportunity to work with him. So tonight, he's going to tell you about advances in cancer immunotherapy and the things that have happened over the past decade in lung cancer immunotherapy, in the lung cancer immunotherapy field. So thank you very much, Dr. Herbst. I'll turn it over to you.
Thanks, and welcome to everyone. I'm really sorry that I'm not with you tonight. If we could have the first slide, please.
Well, you're a little bit quiet. Just maybe give us 1 second to see if we can make you louder.
Sure.
Well or no?
I can go get some earbuds too.
I'm not sure.
What do you all think? Can you hear them okay, or shall we work on the volume? Up. They're saying up.
Let's see.
How's this now?
About the same.
What to do?
We're working on it from our end, seeing if we can make you louder. Should I do something here, you think?
I think might be. Oh, here we go.
Do you want to go ahead to the next session?
Oh, I think this might work. Hold on. Try now.
Hello?
We did it. Thank you.
Okay, they're trying to mute me. Well, listen, if we could have the first slide. I'm so honored to be joining. I've been to this event pretty much every year since I've been here, which is almost 15 years. And if we can have the first slide.
Working on it.
Technology.
Okay.
Okay, so what I thought I'd do is talk about advancements in immunotherapy. I bet there are some people in the audience who are on immunotherapy, who know someone who's on immunotherapy, who have seen immunotherapy on TV. So I just talk a little bit about what it is and why it's important to get us started tonight, and to show you that we are making progress. The next slide, please. So the reason I'm not there is I'm actually in New Mexico, Albuquerque, at a conference that I'm co-leading, which is used to be called Diversity in Clinical Trials. Now, if you hit it again, please, Sarah. Now it's called Excellence in Clinical Trials, given the current climate in the United States, but still the same thing. We're teaching 80 students, young faculty, how to do clinical trials in the community. And actually, we have 5 people from Yale here with me, including So-Yeon Kim, who I'll be seeing in a few minutes, one of our lung cancer doctors. Next slide. So what Katie, myself, Sarah, and all the people here really do is translational research. What we're trying to do is take discoveries from the bedside on the left and understand what we need, and then go to the bench, the lab bench. Dr. Politi has a lab where she's studying different models of lung cancer and then finding new therapies, and then we bring them back to the bedside so that we can help patients with this disease. The next slide. So what about immunotherapy? Next slide. So immunotherapy, if we click this twice, began over 100 years ago by Dr. Coley in New York. What he used to do is he used to put bacteria and actually inject them into tumors, and that would create an inflammation, and that inflammation brought in immune cells, and that was actually the first immunotherapy. But immunotherapy at Yale, if we can click again, began with actually Dr. Mario Snow, and Mario, who's actually leaving us and retiring this year. But Mario, 16, 17 years ago, recognized that immune therapy was something that would help lung cancer, melanoma, a type of skin cancer, kidney cancer, and he brought some of the earliest trials to Yale. On the next slide. And then it's really been a team, and I'm sure Dr. Gettinger's there, and he looks the same now as he did in this picture 10 years ago. There's Dr. Gettinger, Dr. Snow, Dr. Kluger, and then Li-Ping Chen. These are really the pioneers here who started working with immunotherapy at Yale in early phase trials, and some of you may have even been on them. The next slide. And Li-Ping, who's highly honored scientist in all the national societies, really was one of the first people, top 4 or 5 in the world, who discovered what's called PD-L1, which is what makes immunotherapy possible. And I'm going to show you now on the next few slides what that is. So many of you have seen immunotherapy, but what is it? Well, the immune system is very special. It's specific, You don't want to make a reaction against something that's normal. Otherwise, you'll have something like poison ivy. You'll have a very bad problem. The immune system has memory, meaning once you have a reaction, once you have antibodies, they stay around. And it can be adaptive. It can change depending on the circumstance. So what you see here is you see the tumor cell. And see that little red dot? That's the abnormal tumor protein on the tumor cell. So what happens is, if you click again, please, the immune system, the T cell, can recognize through a very specific mechanism, it can recognize that tumor cell. And you would want that to kill it. But that doesn't happen because if you look at the next click, there's a loop. There's a feedback loop that protects the immune system from killing that tumor. And see that little red line? That's an inhibition that occurs through something called PD-1. So the bottom line, when you hear about a PD-1 inhibitor or a PD-L1 inhibitor, what it's trying to do, if you click again, please, it's trying to block that interaction. These drugs that one gives to a patient that some of you might take, that your friend or family member takes, it blocks that interaction. And what that does is it allows the immune system to do its thing against the tumor. It recognizes the tumor as a foreign invader. And if you click again, you'll see that it can have amazing results. So Maureen, shown here, and she might even be in the audience, was one of the first patients who was treated. And you can see that she's now 15, 14 years in, and she received a phase 1 trial. So that's the beauty of a place like ours at Yale, the top clinic at Smilo, is we have drugs that are early drugs that were clinical trials. Now they're the standard of care. 20, 30 million people have been treated worldwide with these drugs. But the first trials were done here at Yale with great effect. That's the good news. The bad news is they don't always work quite as well as we want. Like any process in nature, tumors learn how to become resistant. And that's why we're continuing to find cancers earlier and use these drugs. Next slide. This is actually another drug. It was originally a phase 1 trial, MPDL3280. Now the drug is known as atezolizumab. We did some of the earliest studies with this drug at Yale. You can see on the top, someone with lung cancer. See those red lines? Those are lung tumors. And look how well they responded just after 8 to 10 weeks on the drug. See there's nothing where those arrows are on the right. If you look at the lower left, what you can see is CD8 cells, which are the killer T cells, the ones we want to upregulate. You can see they're very low pre-treatment, but post-treatment, there are a lot of them. So this is what we can do. We can reactivate the immune system with these checkpoint inhibitors. It's really fantastic. I've never seen anything like that. In fact, I'm going to be talking to the students here at this course tonight in my opening lecture about the progress we've made in lung cancer, and this is just part of it. And you're going to hear a lot tonight. You're going to hear about what we're doing, and you're going to hear about advanced disease, early disease, and about screening and prevention. On the next slide. And then this is just Dr. Goldberg, Professor Goldberg now. Dr. Goldberg, actually, when she came here in her early career, working with Dr. Kluger, the melanoma leader, and Dr. Chiang, who's our neurosurgeon, some of you might know her, she does all the radiation to the brain. They did a study where they actually took a drug, pembrolizumab, some of you might know it as Keytruda, and did the very, very first study where they took patients that had brain disease, cancer in the brain, and they didn't radiate those patients, but they gave those patients this drug, Keytruda, and you can see those 2 red lines that tumors in the brain responded. This was phenomenal because why take radiation when the immune therapy will do it? And I can tell you that I remember when they called Sarah and Harriet about President Carter, who had melanoma. For 10 years, he lived with brain metastases because he got Keytruda, pembrolizumab, as per the routine developed here at Yale. Next slide. I'm just about done. So we already saw this. Next slide. I should have removed that. So we have a spore. Katie and I lead a large grant here at Yale. So we're constantly trying to raise the bar. And if we just click quickly, because my time is running out, we're studying on the first project how to work and do even better with immune therapy, because we know sometimes the immune cells can't get to the tumor. There's a force field. So we're figuring that out. And we're also figuring out how to deal with targeted therapy that you'll hear about from Scott next. And next slide. Here's the group. This is my last slide. It's a team. I'm just so proud to have been a member of this team, and being a member of this team. This is why, even though it's still pretty early here, I wanted to make sure that I could get on the call today to tell you how excited I am about this wonderful team that you're going to hear from tonight. Thank you all for having your trust in us. And I look forward, I'm going to watch the program for the next hour myself. So thank you.
Thank you very much, Roy. And we have time for a couple of questions. Are there any questions?
And Katie, you might want to tell them what this picture is.
Oh, sure. This is a picture from one of our lung spore meetings that we hosted here in June of 2024 at Yale. So this is the Specialized Program of Research Excellence, and we hold a grant on this in lung cancer. And so we hosted all the other lung spores from across the nation. And we took the opportunity in 2024 to really recognize the anniversary of the discovery of EGFR mutations in lung cancer. They were discovered in 2004, so it was the 20th anniversary. And we hosted this event here and had all of the people who discovered the mutations and the people who developed the therapies that are used now to treat EGFR-driven lung cancer. So it was a very special occasion.
It was quite a powerhouse of lung cancer experts. And, whenever we take care of you, we're always asking others, what's going on in other places. Look in the very upper left, that's Tom Lynch, looking a little askance there. Top or left, our former director. But everyone came for this because they were so excited about the collaborations.
So any questions? If not, I'm going to ask you a question, Roy. What are some of the other immunotherapeutic approaches that are being developed now? So what are some of the things on the horizon in terms of immunotherapies that we should be thinking about and keeping an eye out in lung cancer beyond immune checkpoint inhibitors?
Right. So that's a great question. So the immune checkpoint inhibitors relieve the block. So that's the first step because, in order to get the water in, you have to relieve the block. But then we need ways to bring more immune cells into the tumor. And now we have this whole field of what's called T-cell engagers. They're molecules that actually go to the tumor, to the cells around the tumor. We call that the stroma, the microenvironment, and they actually attract T cells. We call them T-cell engagers. You might hear them called bispecific antibodies. In small cell lung cancer, there's a drug that Chiang is studying called tarlatinib. So those are very exciting, and keep your eye out for those. The other thing that we have are vaccines. Vaccines, I'm a strong believer in vaccine. I've had all my vaccines, but vaccines will work in cancer. The problem is we have to figure out first, what the protein is to target. And that requires a great deal of study and work. We're doing that here, but we're actually studying vaccines where you actually get a vaccine that stimulates the right immune cells to go after the cancer. So that's ongoing right now as well. And then we're combining things, it looks like we're going to have to combine some chemotherapy with immunotherapy, maybe some anti-vascular agents with chemotherapy. We're trying everything, and we're doing it in that bedside way that I told you about to try to figure out what the best ways are. These will be so many of these will be protocols. So be sure to ask when you're in the clinic, if you need something else, what are the protocols? What are the studies? Because as I showed you, everything I showed you here, you could only get at Yale 10 years ago, and now it's standard of care. So now we're working on the next generation of studies.
Thank you very much, Roy, and enjoy the rest of your time in Arizona. Thank you very much.
Thanks.
Oh, New Mexico. Why did I think Arizona?
I wasn't going to correct you, but they look very similar, but it's very nice.
So we are going to move on to the next session. So we have 3 talks that are on some new emerging therapies. And so we're going to go through these 3 5-minute talks, and then we'll have time for some questions if you have questions for the speakers. So our first presenter is Dr. Rick Wilson. Dr. Wilson is a physician scientist, and so he works in the lab in addition to practicing as a thoracic oncologist. And so he's going to tell you about some of the newer targeted therapies that are emerging. So I'm going to turn it over to Rick. Thank you.
Great. Thank you, Katie, for the kind introduction. And thank you all for being here this evening. I'm excited to have the opportunity to provide a brief overview about recent developments in targeted therapies in lung cancer. These are therapies that are developed specifically to target gene changes or gene alterations that we find in subsets of lung cancers, with the goal being to try to stop those cancers from growing and spreading. And so on the slide here on the far left, this is showing you some of those gene targets. And then to the right, what is being shown is a timeline showing you the development of specific therapies against those gene targets. And the purpose of the slide is just to show you that over the last 15 years, we've actually seen the development of many new targeted therapies in lung cancer. And of course, this is very exciting to us because we always want to have as many treatment options as possible to consider for our patients. And in fact, when we meet new patients in the clinic and in the outpatient setting, especially those with a diagnosis of a specific type of lung cancer called lung adenocarcinoma, we're always thinking to ourselves, is this patient potentially a candidate for one of these targeted therapies? So this is a pie chart showing you the frequency of some of these gene changes in lung adenocarcinoma. And you can see that some of these gene changes are fairly common, such as KRAS, shown in green in the upper right, or EGFR, shown in navy blue below that. Whereas there are other oncogenic or other gene changes that are less common. One of these less common gene changes is called HER2. And we see gene changes in HER2 in about 3% of our patients with lung adenocarcinoma. And we've never had any targeted therapies for our patients with lung cancer that have HER2 alterations. But that's changed. In just a few months ago, the FDA recently approved a new targeted therapy called zongertinib for patients with advanced lung cancers with HER2 alterations. And this is the first approved oral targeted therapy, meaning pill that can be taken by mouth for our patients with lung cancer with HER2 alterations. And we're excited to be able to now offer this to our patients as part of standard of care. But there are actually other agents also in clinical development. And here at Yale, we actually have a clinical trial of one of these new targeted therapies called ORIC-114. This is being evaluated both in patients whose lung cancers have HER2 gene changes, but also in patients whose lung cancers have certain EGFR alterations as well, making this a targeted therapy that is potentially relevant for two different gene targets in lung cancer. I mentioned that one of the more common gene changes that we see in lung adenocarcinoma are KRAS gene changes. We see these in about 30% of our patients with lung adenocarcinoma. And this is a gene target that we have known about for decades. But for decades, we have not had any targeted therapies against KRAS. That has recently changed in the last couple of years with the development of an FDA approval of two targeted therapies, one called sotorasib and one called adagrasib. These are approved for our patients with lung cancers, advanced lung cancers, having a specific KRAS alteration called G12C. And as you can see in the pie chart in the middle, G12C is the most common KRAS gene change that we see in lung adenocarcinoma. But we're always trying to do better, and there are newer targeted therapies directed against KRAS G12C that are being evaluated in clinical trials that may work better than these agents. And we currently have a couple of clinical trials looking at two different new targeted therapies for KRAS G12C, one called divarasib, one called olomorasib. Finally, if you look at the pie chart, one thing that you'll notice is that there are a lot of other KRAS gene changes in lung cancer that are not G12C. And we currently do not have any FDA-approved targeted therapies for these patients. But again, there are new treatments in development that are being looked at in clinical trials. And we actually have a clinical trial here looking at one of these new targeted therapies called daraxonrasib. One of the things that is particularly interesting about this targeted therapy is that it can actually target multiple different KRAS gene changes, which is a really innovative new development in KRAS targeted therapies. So this is just to give you an overview of some of the new therapies that are coming down the pipeline, and we're excited to be able to offer access to these therapies to eligible patients here at Yale through our clinical trials. Thanks.
Thank you very much for that. Our next speaker is Dr. Ann Chiang. Dr. Chiang is a thoracic oncologist and an expert, especially amongst other things, on small cell lung cancer. And she's going to be telling us about bispecific antibodies this evening. Dr. Chiang, thank you.
Perfect. What a great turnout. I spoke this weekend in New York at a patient, the Cure Lung Summit, and there's twice as many people here. So you guys turned out tonight. Thank you so much for coming. I know it's at the end of a long day, so really appreciate your interest. And one of the questions at that summit was, how do we get folks to ask more questions? And what I said is that it's really important for us as doctors and us as nurses and your care team, the more questions you ask and the more you understand about what's going on, the easier it is for us to do our job, and actually the better we can do our job. So thanks for coming tonight. So I have been given the topic of bispecific antibodies in lung cancer. So I'll start with that. What is a bispecific antibody? So in this, I don't know if I can point to it here. Okay. No. Okay. Well, oh, it was? Okay.
And you have a laser too on the.
Can you see my laser? Yay. Okay. So an antibody. So this antibody here recognizes a protein called CD3 on the surface of the white blood cell. And this antibody in purple or red recognizes a protein called DLL3 on the tumor cell. So a bispecific antibody basically is an antibody that can bind to two different proteins. And here you see this drug tarlatamab, an antibody that has, and it binds both to CD3, that's in orange, and in purple, the DLL3. So it brings together here the T cell to the tumor cell, and this activates the immune system to attack the cancer cells. And this is so great because you notice here, there's no chemo involved. You're actually just taking your immune system and bringing it over to your tumor cells. So it's really exciting. You can avoid a lot of those toxicities that chemo has. And that's why we're actually really excited about this. So there are already FDA approved bispecifics. So these are hard to say, but I'll try. Blinatumomab binds CD3 T cells to CD19 B cells, and that's been approved for leukemia. Tebentafusp targets GP100 protein to anti-CD3 on T cells, and that's approved for the use of melanoma in the eye. And then amivantamab is another FDA-approved non-small cell lung cancer drug, and it binds to EGFR and MET, and it's been approved for EGFR exon 20 insertion mutations, so those patients. And this is a waterfall plot. Each line is a patient and how much shrinkage of their tumor has occurred. So we like all that shrinkage to be below the line. In this case, you have some folks who have 100% shrinkage, which is fantastic. So this is a slide actually I got from Dr. Goldberg, and it's a little complicated, but basically I'm going to walk you through it. So all of these are different targets on the surface of cells. And so bispecific antibodies are targeting any number of these, including ones that are associated with tumor cells, ones that are involved with the immune cells, and ones that also target PD-1, PD-L1, like Dr. Herbst was mentioning, et cetera. And so these are the number of antibodies that have been developed. Each line is a different antibody. In this tells you that in 2011, there were 12 clinical trials with bispecific antibodies. In 2023, there were 62, and now I think there's upwards of 100 and some. And these are all the different tumor types. So non-small cell lung cancer is at the top there with 62 trials. So very exciting area. Okay, now I'm going to switch for a moment to small cell because this drug was just approved last year. And this bispecific, again, makes a lot of sense here in small cell because this slide here on the left, the blue cells are tumor cells, and this is a baseline biopsy before treatment. And what you can see there are a lot of tumor cells, but there aren't pink or yellow cells. Those are the white blood cells. And then this is not specifically tarlatamab, but the idea here is you can see massive infiltration of a lot of different white blood cells, and that we think is what is helping to activate the immune system to recognize the cancer cells. So this drug in small cell lung cancer, this was the Delphi 301 trial that led to FDA approval. Just pay attention here. So in 40% of the patients, they had shrinkage of their disease. Another 30% had stable disease. So that means about 70% of the patients were responding to this drug. And all of those patients had already been treated with 2 different lines before that of treatment. So this is on the basis of this, this drug was approved by the FDA last year, and then another trial in June confirmed the results and actually showed if you compared patients treated with tarlatamab to patients with chemotherapy, there was really a positive, you could extend the overall survival by 5 months. So really exciting. And the other thing I didn't mention is that those patients who are responding, the median duration of response is almost 10 months. So you're not just saying, let's push it out a couple months before you have something that's popping up. It's really 10 months. So that's really great. So briefly about some of the side effects of these kinds of drugs is cytokine release syndrome. So if you think about activating your immune system, if you get a vaccine shot, flu, COVID, sometimes you get some fever and chills that night. You feel a little achy, really tired, over the course of the next day. And so this is similar, but so here over half the patients had CRS, mostly low grade 1 or 2, symptoms of fever, chills, maybe the blood pressure was a little low, the oxygen a little low. These symptoms can be treated with Tylenol, IV fluids, oxygen, and steroids. Only 1% of those patients had more severe grade 3 CRS that went into the ICU for monitoring there. And this CRS usually occurs, again, like that flu vaccine, within 24 hours of the first 2 infusions. So week 1 and week 2 right now, we admit patients into the hospital for monitoring overnight. They can go home the next day. And then the rest of the infusions can happen every 2 weeks in the outpatient setting in the clinic. And we're working on a pilot to do this outpatient as well, safely. So what's next? Well, you heard from Dr. Herbst, when you have active drugs, we want to try to move them earlier in treatment, either first line or in maintenance, or after you have early stage. So those trials are happening now. There are also lots of bispecifics and even trispecifics. And this shows you one where not only is there the CD3 and DLL3, but the antibody also recognizes albumin, which is basically protein in your body, and it helps to extend the half-life. So there's lots of ways to augment this. And right now they're being used in combinations with standard of care and other novel drugs. Super exciting. Keep your eyes out for this. And again, I love it because we're just avoiding chemo altogether. So, all right, thanks. That's it for me. And and thanks for your attention.
Thank you, Dr. Chiang. So Last but not least in this session is Dr. Scott Gettinger. Dr. Gettinger is a thoracic oncologist, and as you heard from Dr. Herbst, he led some of the early immunotherapy trials here. So thank you very much. There we go.
Just advance it here. Nice. Hello, everybody. It's great to see all of you here, and some of you, well, I met you over 10 years ago, so it's really a different world in lung cancer. So I welcome everybody. So I was asked to discuss antibody drug conjugates, and initially my plan was to show you a video that I think describes antibody drug conjugates very well, but my colleagues told me, you don't come here to see a video, you come here to see us talk. So I put some slides together to illustrate this, but at the end, I'm going to show just a truncated version of the video and just to see how I did. Okay. So on the right here, you can see a tumor. So what is a tumor? So you have one cell in an organ, let's say the lung, one cell that does its business day by day. And then for some reason, that one cell becomes 2, becomes 4, becomes 1 million. And that happens because of mutations in the DNA of that cell. The immune system distinguishes a tumor cell from a normal cell based upon proteins that are expressed in the surface. We've heard about this. We call them antigens, okay? And that's how you initiate an immune response to different things, whether it's tumor or viruses. So there are 2 types of antigens, tumor antigens. One is a tumor-specific antigen, which is different patient to patient. So very hard to target these antigens because we'd have to figure out the difference in each patient, and then we'd have to create an antibody. And then there are the tumor-associated antigens. These are antigens that are preferentially expressed on tumor cells. And these might occur in anywhere from 10 to 25% of lung cancers. So here on the left, you see an antibody. And what an antibody is supposed to do, let's just pretend this is not a tumor cell. Let's pretend this is a cell that's infected with COVID. And let's say you've been exposed to COVID before. So when COVID infects a cell, it takes over the machinery of the cell, and it starts making all sorts of proteins. And some of these proteins are expressed. Let's see here. I'm not sure how to show it, but you see these bright, oh yeah. So you can see these. So one of these might be a COVID-associated antigen. And so when that happens, we have antibodies that are made by our own immune system, by our B cells, and they come and they recognize this infected cell, and they flag the immune system to destroy the cell. So you've heard a lot about antibodies, and the antibodies that you heard about tonight are ones that we create. So in a case of a tumor-associated antigen, we might not have antibodies because these antigens might have been expressed on normal cells early in development or on some rare normal cells now in low degree. So we have made antibodies against some of these antigens. We initially just started making the antibodies, and there's one, for example, called cetuximab. Anyone remember Martha Stewart? She went to jail because of Erbitux. Okay, so that was an antibody to one of these antigens, and problem is it didn't work that well. At least in lung cancer, it didn't work that well. So we need to do better, and technology has allowed us to modify antibodies in all sorts of ways. So these are the 3 components of an antibody drug conjugate. Okay, you have the antibody. We call it a monoclonal antibody that's created. And then we have a linker that links a warhead, in this case, chemotherapy, to the antibody. So now you can have the antibody that's going to circulate around the body. It's going to find the tumor cell, and it's going to bring this chemotherapy smart bomb along with it. So blowing this up a little bit, let's just start here. So let's say, in clinic, I have a big arrow so I can see it. I can't see it here. But anyway, you probably see it. They make fun of me, but so this is the tumor, right? And here are some antigens on the tumor. And this is the ADC that you get through an IV infusion. And let's say this is an ADC that recognizes something on a tumor called TROP2, okay? So here you see in brown, this is TROP2. So the antibody drug conjugate binds to this antibody, binds to this antigen, and then this causes the cell to take in the antibody in a process called endocytosis. And once in the cell, the antibody inside of an endosome merges with a lysosome, which allows cleavage here of the chemotherapy from the antibody, and now the chemotherapy can do its effect, can kill the cancer. There is another potential effect called the bystander effect. So once this chemotherapy is released, it can permeate into nearby cells, regardless if those cells express that particular TROP2 antigen or not, and cause cancer cell death. So currently, there are many of these antibody drug conjugates in development for non-small cell lung cancer on the left and small cell lung cancer on the right. 3 of them are currently FDA approved, and I can see one person who's on one of them. One is for a protein called c-Met, and here you can again see this is the surface of the cell, and here are the antigens that are expressed. One is for TROP2, and then one is for HER2. So we here are running several clinical trials looking at new antibody drug conjugates. And now that I've gotten to this part, I'd like to show 2 minutes of a video. Is that okay? Because I think if I can figure out how to do this. Oh boy.
Antibody drug conjugates, or ADCs, are a kind of cancer treatment approved to treat a variety of cancers. ADCs were created as a way of delivering chemotherapy drugs directly into cancer cells, with the goal of minimizing damage to healthy cells. You can think of them as a kind of targeted chemotherapy. As their name suggests, each antibody drug conjugate is comprised of an antibody, a drug, and a linker that holds them together. Antibodies can precisely locate and bind to specific proteins found on the surface of cells. So the antibody component of an ADC is designed to precisely locate and bind to a specific protein found mainly on whatever type of cancer cell is being targeted. This antibody serves as a guided missile to deliver to the inside of the cancer cell tiny payloads in the form of a potent chemotherapy drug. Because the chemo is being delivered directly to the cancer cells, ADCs can use a very low dose of a more powerful type of chemotherapy than the kind of chemo that is delivered throughout the body. Finally, the linker is designed to help prevent the chemo from releasing until it reaches the target cells. ADCs are delivered through an IV. The antibody component of the ADC seeks out cancer cells by looking for the protein it was designed to identify. When the antibody binds to this protein, the cell responds by pulling the ADC inside the cell. Once inside the cancer cell, the linker breaks down. This releases the chemotherapy payload so it can destroy the cell. Now, within a tumor, there may be cancer cells that don't have the target protein. Some ADCs are able to destroy these cells too. That's because their chemo payload can seep out of the targeted cells to reach neighboring cells as well. This is called the bystander effect. There are more than a dozen ADCs approved for...
All right. That's enough. I was going to show longer initially, but all right. Thank you, guys.
Thank you all. So I'd like to invite Dr. Wilson, Dr. Chiang, and Dr. Gettinger to just come up here so that they can answer some questions. Does anybody have a question? Yes.
I don't know if I need the microphone.
Well, I'll give you the mic. I'll pass it down.
Yeah, my question is regarding heated chemotherapy. I read something, probably in a Cure magazine, that it's going to be a game changer. So is that something that you folks are working on, or?
Certain spaces we have. So there's certain spaces in the body, like the pleural space, which is a bag that's around the lung. We have the peritoneum, which is sort of a bag around all the organs in the abdomen. And in those situations, we sometimes will try to, well, we won't, but it's been done where you heat a chemotherapy and you put it into that space, or you put some other thing into that space, whether it's another immunotherapy, and that can cause cell death, within that area. It's particularly used for mesothelioma, but we have a program here, a guy who does mesothelioma for the peritoneum, and he wants us to do this in the pleura. So we're beginning to do this, but it's really a local effect. There might be some subsequent immune activation, but it's more local right now.
So when you say local, that means just to say, per se, like the
Cancer
lung
cells
here.
within that cavity. you know, where the cancer cells line that cavity, and often you have fluid that's produced because that cavity, the lining has holes in it, and you get pleural effusion. Some of you might know what that is, where you get fluid around the lung or fluid around the abdomen, ascites. It's really supposed to treat local disease, but once you get cell death, you can have an immune response, and that immune response can extend beyond that area.
Thank you. Can I ask one more question? AI, where are you folks in that whole process of getting that fully implemented at Yale? Are you the beginning stages? When do you expect it to be fully functional?
It's not me.
So AI is super interesting now, and there's so many ways that it can be used. I think that right now there's a lot of interest, for example, in pathology. So there is work being done where you can, we talk a lot about mutation targets like EGFR, and how you can sequence and look for that in DNA. There's work around looking at the pathology slide, the digital pathology slide, and being able to determine whether or not you have an EGFR mutation just from looking at the slide, and teaching folks to do that. And so you can imagine that would be really important in places where you don't have access to the pathologist or to the sequencing. So that's one area where it's really important and active. Another area is with radiology, right? So right now we have radiologists looking at the scans, but if there's a way that we can help to augment that by, training AI to look and see if there are particular characteristic patterns of cancer. And especially if you're looking at a scan, maybe after you have surgery, or, could you look at that and have, see a pattern that might put you at more risk of developing recurrence or less risk. And then you could do more therapy or monitoring or in the high risk patient, or vice versa. And that's something that was just presented at ESMO recently. And so there's a lot of activity, utilizing AI in all sorts of the things that we do. And I think it's sort of rapid learning, and we're all trying to put our heads around that and see if it can help us in our and help patients.
I think we have time for one last question. Yes.
Has immunotherapy reached a level where it's used only by itself and not in conjunction with chemotherapy as well? Is it always used with chemotherapy?
Yeah, that's a great question. There are some situations where we might use immunotherapy alone. We do use it sometimes in combination with chemotherapy. One of what we call biomarkers that we use to kind of help us to determine what the likelihood is of a patient with a certain type of lung cancer called non-small cell lung cancer of benefiting from the immune therapy is looking at the tumor PD-L1 expression. We've heard about PD-L1 tonight. And sometimes that can give us a sense of what the likelihood of benefit is to immunotherapy alone. It's not a perfect biomarker, and there's a lot of research going on, not only looking at PD-L1, other biomarkers as well, genetic characteristics of the cancer that can be important in helping to kind of formulate the optimal treatment plan for a given individual patient. And that might involve immunotherapy alone. It might involve immunotherapy together with chemotherapy. And there may be certain contexts or situations where immunotherapy isn't a good choice for an individual patient.
Thank you very much. So thank you very much for the speakers in this session. I think you heard about some new emerging therapies that are really exciting and things for us to keep an eye out. Thank you very much. All right, next we have a panel, and that is going to be moderated by Dr. Justin Blasberg, who is right here.
How are you guys? So this is actually the keynote part of the presentation. So welcome to our session. We're going to talk about lung cancer screening, early stage lung cancer, and a few topics. And we'll have the group introduce themselves, and we'll run through some questions. We surveyed 1,000 people to look for the most important questions that you guys want to know about, and we'll review some of those things today.
Sure. Hi, Gavitt Woodard. I'm a thoracic surgeon here at Yale, and we treat a lot of lung cancer in our practice.
Polly Sather, I'm a nurse practitioner and I coordinate our lung cancer screening program.
Hi, I'm Lynn Tanoue. I'm a pulmonary critical care physician and I direct the lung cancer screening program. And I also see a lot of patients with lung cancer.
Good evening. I'm Christina Fuss. I'm a cardiothoracic radiologist and I read all these lung cancer screening CTs.
So this is a modest group. If you're having lung cancer screening anywhere in our system, probably this group touches your scan in some form. That's thousands of scans and a pretty impressive encatchment. So we're fortunate to have this group today. I wrote my questions down so that we can be timely. We're going to start with Polly. Polly is sort of keeps the wheels from falling off the bus of the lung cancer screening machine. We were going to start with some questions mostly about where we are today with lung cancer screening. Many of you may know who qualifies for lung cancer screening, but we're going to review that quickly and then sort of talk about where we are in 2025 with the success of our program, which has evolved over time, and what the future looks like. So why don't we just start with an update on lung cancer screening and who qualifies?
Sure. So my job kind of is to keep you guys having a lot of free time so we don't have to talk about those ADCs and give you guys a lot of business. But so lung cancer screening, we've had recommendations in the United States since 2015, but really in March of 2021, the recommendations by the United States Preventative Task Force were updated to broaden the eligibility criteria, which right now includes anybody 50 years to 80 who smoked cigarettes, a pack a day for the equivalent of 20 years, still smoking or quit within 15 years. So that's the current eligibility criteria, and the way we screen is with a low-dose CAT scan that your group reads, and we're very fortunate here at Smilo to have a dedicated group of chest radiologists that read these scans. It's not a general radiology group that reads them, so that improves our sensitivity and our specificity of these tests. Lung cancer screening, though, has really been slow in the uptake. Like the current nationally, we're only screening about 18% of the eligible population. Unlike breast, which is about 80% get mammograms. For colorectal screening, it's closer to like 70%. Prostate's a little lower, about 36%. But I'm really happy to say that in Connecticut, we are number 2 in the country in terms of our lung cancer screening rates. That data just came out from the American Lung Association. We're just behind our small little neighbor of Rhode Island to the north. And we do have scanners from like Warwick all the way down to Greenwich, and we have coordinators at all those sites. Some of them are here, Krista from New Haven, Emily's here from Greenwich, Stephanie from Bridgeport. So we've come a long way in terms of our screening, and we're screening, about 3,000 people now a year.
And in the lung cancer screening trials that we often think about, talk about, and that have shown a benefit to lung cancer screening, one of the biggest parts, the most important parts, is not just coming in to get that initial scan, but it's the follow-up. It's getting patients to come back for the second and third scan so that we follow nodules that may be growing or changing. And how have we, or what have we been doing to help patients with adherence for those recommendations? Because those scans seem like they're as important as that initial scan.
Yeah, so adherence is really worth talking about because in the lung cancer screening trials, the majority of the lung cancers that were found were not in the initial screen. It was in the subsequent screens. So people will have a normal screen and then they do need to come back every year. So before their initial screen, all the coordinators and I, we call everybody and we do what's called a shared decision-making visit. And we talk a lot about adherence and the importance of coming back. We do also have a pretty sophisticated tracking system within our EMR, our Epic system, where we know when people are late, we know if they have critical findings, and we are going to find you and make sure you get something done about it. We also just set up a self-scheduling option in the MyChart if we have MyChart users to help people schedule their scans and to improve our adherence rates.
Great, thank you. So Dr. Tanoue, I'm hoping can help us with probably the most important question tonight, which is why do you think it's important that people, what's the most important reason that people who are at risk for lung cancer should have lung cancer screening?
So I want to ask the audience a question. How many of you have had breast, colon, or prostate cancer screening in the past 5 years? Yeah. So you're a motivated, educated bunch. And the whole point of screening is to find a cancer early. Because if we can find a cancer early before it's causing any symptoms, so you wouldn't know to go to the doctor, right? You're healthy, feeling fine, but you go for your mammogram, do your colon screening, and PSA, the prostate-specific antigen, has had some controversy, but most of you men out there are having it monitored. If you had a cancer, one of those 3 cancers, the likelihood, if it was detected by screening, that you would be alive in 5 years is more than 90%. And so early detection is the reason we're doing screening. Right now, all these fancy drugs, these exciting science that's going on is really directed at advanced stage. They're getting used more and more in earlier stage, but 3/4 of people with lung cancer now are diagnosed at advanced stage, where surgery or radiation are not going to be your best options. You need systemic therapy, and so we need all these drugs that have really revolutionized lung cancer care for that 75% of people who have advanced stage disease at the time of diagnosis. So if we can get lung cancer screening embedded in the community so that instead of being glad that it's 20% now instead of 0, what that means is 80% of people still aren't being screened. We can shift the needle to where breast is, for instance, where 80% of people are diagnosed at 80% of women are diagnosed at early stage. And so breast cancer has become I'm a survivor. It's a chronic disease. I go get checked for it every year or 2, but I'm not afraid that I'm going to die because I know that if something happens, I will be detected early again. And we have to shift the needle for lung cancer there because it right now is the leading cause of cancer death in both women and men. And I'm going to say something which is a little shocking, which is that in the US for the last 2 to 3 years, more women have been diagnosed with lung cancer than men. And that shift in the curve is going to keep getting more pronounced. And so all you women out there and all you men, if you have friends who should be screened, please tell them to go.
Awesome. I think for our radiology experts, as a segue to that, patients are getting lung cancer screening CTs, they're getting CT scans in the ER for shortness of breath, they're getting calcium scoring CT scans, there's scans happening all the time, information's being released to patients immediately, they see all sorts of findings on Epic, on MyChart. They don't really understand what those things mean. And that must be also equally a burden or an extra amount of workload in reading these scans for our radiology colleagues. How do you distinguish incidental findings on lung cancer screening CT scans, low-dose CT scans? How do you determine what's clinically meaningful? How do you determine what's background noise? How do we reassure patients that this little spot that just popped up on the scan is actually okay to watch?
You bring up an excellent point, and to everybody who ever had a CT with a report that scared you, I apologize that this scared you. And I would really encourage you, if this happens in the future, don't be scared and talk to the ordering provider before you go down the rabbit hole of the internet. Please do that. We are legally obliged to put certain things in the report because otherwise they're considered missing. Having said that, there are things that we see on lung cancer screening CTs that are not related to lung cancer screening that are important. As we know, smoking does not only affect our lungs, but it also affects our vessels. All vessels in our chest can be affected, particularly the ones around the heart, the coronary arteries. And so if we read the lung cancer screening CTs and we see a lot of coronary artery calcifications, which is a marker for coronary artery disease, we will comment on that. And if you haven't seen a cardiologist in the past for that, there will be a note in the report saying, maybe you should see a cardiologist and be worked up for that. So this is something that we would not just forget. The same is the large vessel that comes out of your heart, the aorta, can be also affected and it can get large. And so we also comment on that. If it's over a certain measurement, you should probably be seen by a vascular surgeon or also by a cardiologist. Little things in the liver, we usually try to say, it's a little thing in the liver, don't worry about it. And if we say in the report, don't worry about it, then please don't worry about it. We have to say that it's there, but again, it has something to do with that we have to report these things. So in short, if you're worried, don't ask Dr. Google, ask your ordering provider, ask your PCP, ask your pulmonologist, ask someone who knows, and please don't be scared. Thank you.
I'm wondering if we could also just touch on emerging technologies. Someone asked about AI and radiology and pathology and other emerging technologies in the radiology space that are useful for lung cancer screening, what we might expect on the horizon.
Well, obviously, there's a lot of technological developments going on. One of the things that many people still fear is I'm doing screening with ionizing radiation. I'm exposing myself to something that is per se risky. And one of the reasons why lung cancer screening actually made it to where we are today is because we were able to show that the risk from the radiation outweighs the risk or the benefit from being screened. Having said that, with our newer technologies, we're now able to reduce the radiation dose even further. So it gets now into the realm of maybe a handful of chest x-rays, which are unfortunately completely useless to screen for lung cancer. But the CT is useful, yet the dose is similar. So that's a significant change that we have. And we are going to have that particular scanner I'm talking about next year. So I'm keeping my fingers crossed. I'm very excited about this. AI was mentioned. AI is ubiquitous. We have it at our discretion every day, regardless where you are. We also have it in the reading room. There are some tools that look at patterns in CTs and try to recognize, is this bad? Is this good? Has this changed? Has it grown? Has it not? The challenge with these is that the no CT is the same. So if one of you were to get their CT this year and then next year, even if you go to the exact same place, it will not look entirely 100% the same. And so we have to find ways to assess for the minute changes that are simply because it's a different CT to the changes that are actually true growth or true changes in what we describe density. That's a term that we use when we describe things in the lungs. So I'm excited. There's a lot of development. At the end of this month, there's our big annual international meeting in Chicago, and I'm sure that the vendors are going to be full with this. So I'll report back. Thank you.
And then for Dr. Woodard, maybe our last question before we ask the crowd if they have questions. Lung cancer screening, calcium scoring, CT scans, all of this imaging has generated a lot of early stage business on the surgery side. And I'm wondering if you could tell us about how that has changed your practice in terms of volume of cases, the type of surgeries that you're doing, and maybe touch on the robotics program as we have built that up quite a bit with your help.
Yeah, thank you. As was mentioned previously by Dr. Tanoue, the goal is to shift a diagnosis from a cancer that would have been caught at a very late stage where the treatments are more challenging, our likelihood of cure is less, to a much earlier stage where it's a lot more easy for a patient to undergo a lung cancer treatment. So I'm a surgeon. If you're diagnosed with a stage 1 lung cancer or found to have a lung nodule that we don't even know what it is, The treatment for that is either going to be something like an operation that we would do, and I'll talk about that, or radiation therapy if you're not a surgical candidate. These are a lot easier therapies to endure than having systemic therapy. All the new cool chemotherapy drugs are great, but the ideal treatment for a lung cancer would be to catch it in this very early stage where we can take it out with a lot better health benefits to you, more likelihood of a cure, as well as, not putting you through the systemic therapies. So we do most of our operations here with robotic surgery, as was mentioned by Dr. Blasberg, who leads up our robotics program. And they're all small incisions on the side. I like to tell patients they're the size of my finger, and we basically put ports between your ribs. We put cameras and long instruments in between your ribs, and we're able to remove tumors that way. We can remove lobes, and most of our operations are done this way. Patients leave the hospital in a few days. They don't have these big incisions, and they do really well long term. And so the earlier we catch a cancer, the more likely it is that we're able to treat it with just these interventions alone. And stage 1 cancers at the moment are not getting any more systemic therapies. We're just treating you with this, and then you're done, and you go into a surveillance mode where you're basically getting your annual CT scan eventually just every year to monitor for any signs of recurrence. So it really does make a dramatic difference in what the treatments are like for lung cancer if it is caught at an earlier stage. And so that's why we push these initiatives of lung cancer screening, because it makes a difference in how people do in terms of outcomes, but it also makes the treatment a lot easier if you are found to have a lung cancer.
Sounds great. I think just for the sake of time, does anybody have questions for this panel, this group?
Do you have some notion about the people who are not in the current recommended group, the 50 smokers, the earlier ones, and what the incidence is in that group, and is there any thought about or movement to expand that pool? I have a little personal investment in that my wife was diagnosed with early stage lung cancer because she tripped at home and thought she hurt her ribs, and the imaging showed up that early stage.
It's a fascinating question. I think maybe we'll ask Dr. Tanoue to expand. What about family history? What about exposure history, occupational exposure? Those questions are fascinating.
So we are stuck right now with the criteria that Polly outlined, but we know that that's not going to find about half of the people who will get lung cancer. And so one thing is the American population is changing, and there are a lot more people who never smoked in this country than there were 10, 20, 30, certainly 50 years ago. But we're not seeing the lung cancer rates falling precipitously because of that, although they're coming down. So fewer people are dying. But because the population of the United States has gotten so much bigger, there are actually still a lot of people with lung cancer. And so there is a lot of interest in defining risk outside of cigarettes. And there are now really good models that can incorporate things like, besides age and smoking, are you male or female? Do you have a family history? Were you exposed to asbestos or other carcinogens? And the future of lung cancer screening really is that there should be a way to combine all that patient individual information with blood tests. And so if we could find some of those genetic mutations in blood, and we know that somebody maybe demographically has more risk because they have a primary relative with lung cancer, that should then expand the pool of people, perhaps to the general population, who would then have that sort of relatively non-invasive testing. I mean, a PSA is a blood test after all, so this would be blood tests with patient characteristics. And I think that is the way that this is headed, and hopefully really within the next decade, your wife won't have to be diagnosed by accident.
Any other questions?
Yeah, question. Just smoking. I mean, what about toxics and other, air stuff in the air can cause tumors in the lungs as well? And that's one part. And second is, why don't medical doctors in the beginning check for this at a certain part? I mean, why does there have to be an incident for them to check to see if you have cancer? I mean, I mean, in my case, I was kind of lucky. I just really fallen down. If I didn't fall down, I wouldn't have known I had it, you know?
All right, everybody go out and fall down, all right? Because we have 2 falls. I think you're touching on what is really the challenge right now. We want to screen everyone. But if we did a CT scan on everybody, then even with the tiny dose of radiation, we'd be exposing a lot of people to consecutive scans who will never get cancer. And so that these risk models that I was talking about do try to incorporate things like exposures, although it's really hard to quantify, to measure how much exposure I may have had from air pollution versus somebody else who lives in another city, for instance. And so I think we have to get more sophisticated than that, and that really is going to be a biomarker blood test so that we can screen the population.
Why can't a blood test tell you got cancer?
Well, we don't have it yet, but believe me, there's a ton of work going on for that. Yeah, yeah. So, you know, it's truly, I couldn't have said this 10 years ago when we started screening that was on the horizon, but it is. Yeah.
All right, great. Thanks to this panel and to the audience for listening. And we'll move on to our last panel.
All right, so we are moving on to our next panel. We have 2 more panels. This one I am moderating. So this one is called Progression Through Participation. Lung Cancer Clinical Trials Matter. I don't see any panelists here with me. Be asking myself questions. Okay, so come on up. Okay, good. Here are my panelists. Okay. Thought I was going to have to ask and answer the questions. Well, that was cool. All right. So you have already heard during the last hour or so about clinical trials. And the reason for that is, and people have mentioned this all along, is the only way we learn more about cancer or any disease and how to best treat it is through trials. It is literally the only way. We sometimes can do other types of studies, but the best way to make progress, to figure things out, to get the best treatments is to do studies. It's really the only way that we learn more about it, and also that the FDA recognizes a medication or a treatment that should become standard. And so at Yale and at really all cancer centers, major cancer centers where there's research done, this is really a primary goal, because we of course need to treat everybody with cancer, but we also need to make progress, right? We never really settle on where we are now. We always want to do better. I always think until we're curing all cancer, all lung cancer, any cancer, we could always do better. And the only way to do that is through research. So we are all very dedicated to that. And we have a panel here of people that do research for lung cancer and work on trials and other types of research. And really everybody you've heard from today does that in some part. Really everybody at Yale who works here in some way also works on research. So it's something we're all really passionate about. So I will let my panelists introduce themselves and tell you what they do and what role in research specifically they have. And then I will ask some questions and then open it up to all of you. So we have another microphone.
Hey, everybody. I'm Mike Grant. I am a thoracic oncologist. I'm up in Waterbury, Connecticut. And I trained here under Sarah and a lot of these people. And, you know, the main involvement that I have is in clinical research. So seeing patients in the clinic and then trying to think about the trials that we have open, help, you know, use help from our team, and then match patients to clinical trials.
Is this on? Yes. My name is Jennifer Pope. I'm the clinical research manager in our clinical trials office here at Yale. So I manage a team of clinical research nurses and clinical research coordinators who you may have seen in the clinic with our providers. And we work directly with clinicians and with patients in order to bring you clinical trials.
Hi, everyone. My name is Ben Liu. Excuse me. I'm a physician scientist, and so I'm a medical oncologist who sees patients with lung cancers. And then I also do research in a laboratory setting, so a little bit different than what Dr. Grant does. But I like to ask questions and try and understand how our immune system interacts with tumor cells, and particularly what happens when tumor cells go into the brain. How can our immune system, how can we understand how that interaction works?
Right. Superstar team. Ben, keep the microphone because I'm going to ask you a question first. So a lot of people here and at Yale may have heard about a trial or have been asked to be on a trial or participate in a trial, but let's like rewind to the beginning. How does an idea even get into a trial in the first place? So you mentioned you're in the lab. How does something you're working on, cells or whatever you're working on in the lab, how does that become an idea that then finds its way into trial? What's the brief version of the process?
Yeah, that's a terrific question. I think you all saw the end product with what Dr. Herbst had mentioned earlier, what Dr. Wilson, Dr. Gettinger, and everyone has talked about these, what we define as successes in terms of new treatment options for patients. But Dr. Herbst also showed a picture of this huge team of people. And it really does take an entire community of clinicians, nurses, pharmacists, pharmaceutical companies, scientists, to be able to put all of that work together. And part of the reason why everyone celebrated that is because it really does take such a long period of time for us to be able to ask the questions in the lab, show that this is in fact what happens, come up with the right medications to target those pathways, and then to actually bring it to patients. And so, for me as a human immunologist, it starts with, and as a physician scientist, it starts with learning from patients, learning where are areas that we need to improve upon, and then taking that question back to the laboratory and seeing, okay, how can we go about trying to answer what is the fundamental issue here? What is a way that we can address this? And then once we've come up with a model like what Dr. Politi does in the lab that helps us understand whether or not we think this will work in patients, then bring it along into clinical trials and see whether or not we can bring it as a new treatment option for patients.
Great. Jen, I'm going to turn to you. How long have you been working on clinical trials?
15 years, I think, a long time.
Great. So perfect. So I knew it was a while. I didn't know exactly how long. Tell us what you've seen change over the years, because I've been doing this about that amount of time too. And I feel like things have really changed. So a lot of the work that you do is I mentioned this expression before, but really the behind the scenes, right? Making all of this work. So what has changed from your perspective, and tell us a little bit about that behind the scenes, how things actually work with trials.
Sure. So we talk about this a lot on our team, that we used to have a sort of small handful of trials that we could offer to patients. And it was more like we had a trial that we tried to fit every patient into. And now we kind of are able to take the opposite approach, where we have many options and we're really trying to find the perfect option for each patient. And then many options along the way. So right from your initial diagnosis through the process, through multiple lines of therapy, we're able to find specific trials that will work best in those situations, if you're early disease or later disease, all along the way. And now what we're looking at, the questions we're trying to answer are much more broad. So we're collecting, maybe some additional blood samples from you. We're collecting some additional tumor when we're going in for a biopsy, so we can answer these broader questions about why a treatment might work better for one person than another.
Thank you. I always say that we always try to learn as much as we possibly can. It's not just, does this treatment work, but why and how, and if it doesn't work, why not? So I absolutely agree with that. Mike, tell us what it's like when you're seeing a patient in terms of how you talk to them about different options. When might someone want to think about a trial? Is it, you heard from the panel before, is it only for people with advanced disease, or are we thinking about it at different stages? How do you think about it? Do you always think about it for patients also?
Yeah, I do. I think that's the first step. Our job as investigators and people that have access to these trials and try to provide access to our patients is to know the trials, like to know what we have open, to know to an extent, the ins and outs of them and what criteria, how a patient would potentially qualify for the study. And then, that's what I'm thinking about when I see a patient is, is there an option that I can provide for this patient that is a trial that's better than what we can offer off the trial? Ultimately, what we're trying to do with research is really just build on the treatments that are available. Unfortunately, there's a lot of deficiencies in lung cancer treatment, and that is sort of what we're trying to use these trials to do to build on. So I think every trial is trying to answer a question, like Jen said, and every time that you have a patient in front of you, we're trying to we're not trying to fit the patient on a trial. We're trying to find the right option for the patient, which may be a trial and which may not be a trial. So I think it starts with how we understand the trials, how we sort of work with our team to know what we have open. And then, the rest is just conversations with patients.
All right, we're running a little low on time, so I might, maybe I'll open it up to the floor now, and then I could keep going. I have a whole list here, but does anybody have questions about clinical trials or anything else for this esteemed panel?
Yes. How much of a collaboration is between your teams and the pharmaceutical industry? Do you work hand in hand, collaboratively, or do you?
Who wants to take that one?
Hand off trials to one another?
Great questions. Mike, do you want to take that one?
Yeah. So I think, some of our trials that we have open at Yale are in industry sponsored. So trials that we work with companies. Other trials are in the context of cooperative groups, which are large organizations that, try to answer practical questions in cancer care. So we have a mix of these things. And I think, it's our clinical trial team and Dr. Goldberg who sort of, we're always looking for opportunities to bring drugs that look promising. And sometimes these are drugs that are very early in development and that we can sort of work with pharmaceutical companies to bring them to patients in our clinics.
I don't know if they make it for us. So no, it's such a great question, but I'll just say something. You might not realize this, but there's actually lots of people from the pharmaceutical industry in this very room. So we work incredibly closely together. I think so much of what we do, especially as medical oncologists, where we're developing drugs and we're trying to make better drugs, is so much in collaboration with people in the pharmaceutical industry. And a lot of our scientists are working on things, maybe Ben is going to tell us about this now, and then work with the pharmaceutical companies to try to bring those to patients. So it is a kind of a circle of trying to work together to do, to create better drugs, to develop better drugs, and then to bring the trials here so that we can study them better. Ben, go ahead.
Yeah, I just to add to what Dr. Goldberg said, I think that pharmaceutical companies and our academic centers have very complementary roles in terms of the types of the treatments they can bring to patients. One thing that I will say, and I think it's particularly beneficial to be here at an institution like Yale, where the medical oncologists, the clinicians, and the scientists kind of stand side by side, is that we do have the opportunity to ask, probably more unique and to us, interesting questions that pharmaceutical companies might not be necessarily thinking about, or we may have access to, science that isn't as mature, but that we can help to develop. And so, I do think that the roles are very complementary. Certainly, we do work with pharmaceutical companies, but there is also a lot of access to clinical trials that are independent of them.
Nobody hurt themselves, please.
I'll be quick. How do you work out the ethical questions that can arise between these kinds of collaborations?
Very good questions. Jen, do you want to take that since you're holding the microphone? Or does anybody else would like to answer?
I can talk just a little bit about like the research, like consenting process. So when we present a clinical trial to a patient, we are required. We have institutional review boards that require this. There's federal regulations and laws that require us to tell you about all the options that are available to you. So your provider will talk to you about. So that is, yes, exactly. Who's funding it? Who's going to have access to the information about you? All of that is presented to you. I think, in my opinion, one of the critical part is what are the other options? So this is the option that the trial is giving you. And then these are the other options that you should also be considering at the same time.
Yeah, I think it's such an important point, and we and really everyone else tries to be very transparent about it because the pharmaceutical industry is for profit, right? And that is something that you need to know about. And so in every trial, in every consent form, it will talk about who's funding the study, if any of the investigators have do any work with that company. It's all in there. So it's required to be in there. That's not a Yale thing. So that's part of it, so that it's very transparent and you can make an educated decision about participating with that information. Yeah.
Sorry. I think another thing is that clinical trials, I think what Dr. Grant said earlier is that, every clinical trial that we try to offer is really trying to build upon and not on the standard of care, meaning care that you would get with your providers outside of a trial. And I think one behind the scenes look at how we select the clinical trials is that, Dr. Goldberg and Jen and Dr. Grant, every single week, every single day, there's constantly looking to see, what are the most exciting options that they can bring to patients. And so, I think for them in their selection process, for us in our selection process, it really is about trying to find the best option and putting the patients first. Yes, there are ethical considerations when we are working with pharmaceutical companies, but I think it does take a thoughtful approach to be able to present some of the options to you.
Okay, I think maybe one last question and then we'll move on to our next panel.
Just curious if you have a notion about kind of how it breaks down, what percentage of your the clinical trials are that you are part of a multi-site research that involves other research sites around the country, and how much are kind of all housed here?
Yeah, maybe I'll answer that. So most of the studies that we do are not just here. Most of the studies are multi-center studies that enroll at many institutions, sometimes dozens or hundreds around the country and around the world. There are a few studies that we have that are Yale studies developed by our investigators here, a lot of times based on science that comes from the laboratories and then we bring into the clinic. A lot of times those are just Yale studies. They tend to be small studies, but typically the studies that we have are not just here. They're in collaboration with many others. Good question. All right. Any last burning questions, or shall we move on? Okay. Thank you so much to our panelists and for all that you do. Thanks. All right. I'm going to introduce our last panel, which will be moderated by Dr. Dan Boffa, who's the Chief of Thoracic Surgery here at Yale, and he will introduce his panelists or have them introduce themselves. Thank you so much, Dan.
All right. Thank you so much. I'm the last, we're the last act here, so hang tight and we'll try to make this a little bit more engaging if we can. I'll answer a couple of things that came up. Just there was a question about AI and how do drug companies discover new drugs? And just to give you a sense of how crazy the next 5 years are going to be, that DeepMind did a collaboration actually with Yale to look at different drugs to have cancer cells show things on their surface that would make the immune system recognize them. And they tested like 5,000 drugs and narrowed it down to like 5, which is simulated AI experiments. And the 5 actually looked pretty good. And so the amount of discovery that's going to happen in the next 5 years is truly crazy. I mean, the amount of information that's collected on patients every year is like a zettabyte. That's the equivalent to every book that's been published ever 1,000,000 times. So we collect that much data every year on patients, and this is going to be used to totally change everything we know about medicine. So with that, let me have, why don't you guys go ahead and introduce yourselves and say something about yourselves. I'm a thoracic surgeon, Dan Boffa.
Hi there, I'm Henry Park. I'm a radiation oncologist, and I treat patients with all stages of lung cancer with radiation therapy.
I'm Michael Cohenuram. I'm a thoracic oncologist at the Trumbull and 1 day a week in Derby, where I treat lung cancer patients.
Hello, everyone. I'm Chanel Charles, and I'm the social worker on the team.
My name is Michael Glendenning. I'm a physician assistant with the medical oncology team, helping take care of patients while they're getting their treatments.
So we kind of have a loosely defined category here, and I sort of think of it as survivorship. And survivorship is basically everything after you've been diagnosed and started treatment. It's the rest of your life, basically. And I like to think of it as thrivership, because we don't want you just living, we want you thriving. And so all the things that we need to do to help you achieve all of your life goals between the time you're diagnosed and the rest of your life. And so that is the framing for this next little session. And so I'll start with Michael. And I missed the first part. So if somebody wants to just quickly tell me what you guys talked about to be, so the impact of research on lung cancer is truly crazy. I'm sure somebody covered this, but the cure rate for lung cancer has doubled in the past 8 years. We used to get excited when you increased survival by 2 weeks. That was a New England Journal paper. If people live longer by 2 weeks, it was a New England Journal paper. Now it's doubled in the past 8 years. And so we have a lot more people that are living with lung cancer as a chronic disease. And obviously living is preferable to the alternative, but some of these patients are maintained on lifelong therapy. And so, Michael, just in terms of, say, targeted therapy, people who are spending a long time on targeted therapy, what is that like, and what are the ways that we can support them through that in terms of making lifestyle changes, and what does that look like?
Me, Michael, or him?
Cohenuram.
Okay.
G or C? We'll see.
So I agree with Dan. I mean, not only have we gone beyond the point of 2 weeks, but I mean, when we think about when I first went into oncology, less than 5% of people were living till 5 years, and now we're pushing over 40%. I mean, it's really just happening in leaps and bounds. So as Dan said, then we have to think, well, what is life like on treatment? And I remember going to a talk at ASCO last year, and there was a survivor who was on anti-EGFR therapy. And she had a really interesting way of framing it, which was, we think about side effects, and Dr. Chiang talked about this, grade 1, grade 2, grade 3, but even a grade 1, which we as oncologists don't tend to think about a lot, if they have it day by day, year after year, that's very impactful. And the way she described it is, if you had a little pebble in your shoe and you're sitting around, it doesn't really bother you. If that little pebble in your shoe is with you on a 5-mile hike, that's a really big deal. And so we do have to entertain these things. You know, living with a little bit of diarrhea every day for years is impactful. And a lot of it is just communication between the treating team and the patient. What is tolerable to you? What is acceptable? How can we manage this? And for the most part, we can help alleviate almost every side effect, maybe with the exception of some, hopefully to the point where a patient says, this is something I can handle. and they hopefully will feel free to advocate for themselves when they can't and say, I need a break, I need a dose reduction. I think that's really the partnership.
Great. Was that Annabelle Gerwich that gave that talk? My
think
friend.
so,
So
yeah.
so I did not ask him to give that example, but Annabelle just came out with a new book called "The End of My Life Is Killing Me," and it's about her lifelong battle with EGFR mutated cancer. And she's going to be here in March, giving a talk and doing a reading. So just look out for that. She's amazing. But so. Healthcare is expensive, and Chanel, this is coming your way. So, healthcare costs are the number one cause of bankruptcy in the United States, and it is a big deal. It is, people are missing work, and what do you, when you think of somebody that comes in with a diagnosis, how do we approach that? How do we support that? What are their options, and et cetera?
Make sure I get this right this time. Can you hear me? Yes. So thank you for asking that. Now, I am the non-medical person on the team. And of course, with a cancer diagnosis comes with a lot of psychosocial issues, including financial issues. And so there are grants that we can apply for patients. We help patients tap into resources in the community from different agencies. There's a Connecticut Cancer Foundation, there's Cancer Care. So there are different organizations out there that we can apply to for grants on behalf of patients. We also help with government resources. Okay. Okay, thank you. Explore government resources.
Here.
Sure. Thank you. Government resources, some patients may be qualified for Title 19 or other. Yale has an assisted program, a program that they will assist patients pay for their care. So we explore all the options that are out there, whether through Yale or in the community, to help patients pay for care. And not just care, but bills. Household bills, that's a big factor when someone is going through cancer. Now you're no longer able to work, and so the bills fall to the wayside. So we assist patients with getting monies to pay for bills.
Yeah, I think the most important thing is you got to communicate that to your team. These are real things, and you got to be open, and it's all a part of the experience. And sometimes it may mean that you get treated closer to home. I mean, I personally believe you should get as much care as close to home as possible. I think you should have expert care, but I think you should have as much as close to home as possible. That's my opinion. Henry, and Michael, I think this is a fair question for both of you. When you're thinking about the goals of care, both of the things that you guys are offering could affect people's ability to do things in the recovery phase and the after cancer phase. How do you think about that when you talk to people about treatment choices, about decision making, and getting a good understanding of what's most important to them, and how you change your planning accordingly?
So often for stage 1 cancer, for example, often the choices between surgery or radiation therapy, as Dr. Woodard had mentioned earlier, as one local therapy, hopefully without any need for systemic therapy as well. But they really are both very, they're complementary in a lot of ways for different people in terms of who would benefit more from getting surgery and who would benefit more from getting radiation therapy. And it's not so clear cut like an algorithm where you can say, it's very obvious that you should go to surgery and you should go to radiation. Sometimes it's more obvious than others, but there's we'd like to meet you and really discuss what you are interested in terms of the side effects that you're concerned about, the kind of life you're looking to live for the remainder of your life as well, especially when we're in a mode where we're trying to cure your cancers. When we have an early stage disease, we want to make sure that we're fitting along with what the life you're likely to live afterwards. Is that going to look the way that you're hoping for? And which of the two options looks better to you overall. Some folks decide that they want to get surgery because they have the cancer removed. I think psychologically that makes a lot of sense. We don't have a randomized trial yet to prove which is better, surgery or radiation. Often if you can get surgery, many people do. Some, however, if they are candidates for surgery, but they don't necessarily want to undergo surgery for whatever reason, then radiation therapy is a great option as well. But you have to understand the effects it can have on you both in the short term and the long term. So that's why we really try to get to know you in just that hour that we meet in consultation, and then you meet with the surgeon as well, because we want to, and we want to meet your family and get to know what is, your goals ultimately. So that's for stage 1. For stage 3, stage 4, same kind of idea that, here are the expectations of what this treatment can provide, but here's also some downsides, because there's always going to be some potential downsides here for any of the treatments that you undergo. So just the understanding of what it could look like, which could vary a lot depending on the person, but knowing what your risk factors are in terms of what factors may make you more prone to certain side effects and what really matters to you a lot. Some people say, that being on oxygen is okay with them if they need to be on it. Other people say that would really impact the lifestyle I want to live. For example, right? There's, if I ever needed steroid medications down the road, I've been on that before, no big deal. Other people say if I can at all avoid that whatsoever, I really want to do that. So all these things we need to hear about and learn about from you during the consultation. We don't walk in with a clear, we already know what we're going to do for you, right? Because of the fact that, and we want to have options like that, because each individual person can be treated differently, even if you have the exact same scan on the screen or the exact same stage of cancer, same type of cancer. Each person is going to be different in terms of what they're looking for.
Michael, please, if you add to that, or I will give you another one.
That's fine. The conversation makes me think a lot about a great talk that I listened to from a clinician who focused on palliative care, but they talked about when they were meeting their patients that one of the things they really started out with was asking them tell them one thing about them that was just really important for them to know, that they wanted their clinician or their physician to know about their life, their lifestyle, things that were meaningful to them, so that they could have conversations and get to know each other a little bit better and understand what those important things were and how they might be impacted by the therapies that were being offered. And so I think that is a great point. I think that spending time, and I think it's what all of us try to do when we're interacting with our patients, is spending time getting to know them, spending time trying to understand the things that make a difference in your lives, and thinking carefully about the things that we are doing to you to try and help you, but also hopefully not to impair you from doing the things that are so important to you, whether it's playing instruments that could be impacted by the neuropathy from certain chemotherapies, fatigue that devastates you and prevents you from exercising in the ways that are super important to you, and any variety of other things. I think it's just that idea that we really want to get to know you well and understand the things that are important to you to make those choices with you and for you that are best going to serve your long-term goals.
Well, I could keep going. If anybody in the audience has questions, I want to give you guys time.
Here we go.
Actually, I don't have a question. I'm Steve Ham. You two guys saved me a year ago, and I just want to thank you so very much. Okay?
Well, thank you for saying that. I commonly get asked like what it is about us and our team, and it is 7:15. And if you look in that row right back there are five of our nurses are here. 6. Can our team just stand up? I want you guys to just see, this is the type of commitment. This is what separates us. This is how we're able to do the things that we're able to do. So that is really the Yale difference right there. Well, I'll tell you. So a question I commonly get asked is, what can I do to make treatment work better? Should I eat an all blueberry diet? Should I, and I don't know, do you guys have any thoughts about things that people can do? You're diagnosed with cancer. What can they do to make the treatment work better, to make the cancer not come back? Or is there anything that they can do?
Stop smoking.
That's 100%. So the side effects of chemotherapy and treatment are less if you stop smoking. The recurrence rates are lower. It's actually as powerful as immunotherapy in terms of mortality reduction, quitting smoking. So quitting smoking at any age, at any stage, will make you live longer. Expand on that.
Just being active is critically important. We know there's a lot of research that's ongoing, a lot of research that's been gathered over the years. People who are active, and it doesn't mean running marathons or lifting, 300-pound bench presses, but being active on a regular basis really impacts how you tolerate therapy. It impacts survival and how you will do in the long term, and it impacts you in ways that can counteract the effects of the therapies that you're on. So it's really important to find ways that you enjoy being active and that you can be active. And if you're in doubt about what you should or could do, talk with your clinicians about that. They can help guide you for the appropriate kinds of activity for your particular cases.
Yeah, I'll just add to that. I often get asked about diet. We do have dietitians in both medical oncology and radiation oncology who definitely can help with that in terms of how to get enough nutrition in, especially if you're, some forms of radiation, especially with larger field radiation close to the esophagus. If a large length of esophagus is covered, then sometimes we'll have, patients will have difficulty being able to maintain their weight. So we're actually of the, and I think with medical oncology as well, you're often trying to keep people at steady weight, which is this may be different from other parts of your life where you're trying to lose weight. Here we're trying to keep you from losing weight as much as possible, but also to keep on muscle and to keep on, your ability to move and function well also. So I think with just good exercise, good diet, as much as is reasonable, right? Like you're saying, not everyone can do everything, right? But trying to maintain and kind of push yourself to some degree, not overtire yourself, but push yourself to take those steps. There's some people who use Fitbits to try to keep, or even the phones now can track the number of steps you take. So even things like that, simple things like just taking walks and such. You may feel pretty down with your treatment sometimes and want to just lie around to watch TV all day and be in your house all day. But as much as you can just do kind of daily errands, things like that, it'll keep you both mentally and physically sharper.
And I think also it's really critical, again, just communicate with your care team, especially when we think about complementary treatments that a lot of patients will take. And I think sometimes are afraid to bring up with their caregivers. As many very valuable and very safe complementary treatments as there are some that are harmful or that are detrimental because they counteract with the chemotherapies. Talk to us and we will go through each, naturopathic thing that you're taking. We can refer to our integrative medicine specialists. I mean, we want to know everything because we're open to that. We know that there's always room to add to the care of our patients and that sometimes we need to think outside of the box.
I'd like to comment more on the complementary alternative medicine aspect. We've done some studies here on that as well. And I think it's important to understand what the difference is between complementary and alternative. They're often linked together, but alternative really means instead of some part of your care, right? That's recommended from the cancer-related care that's recommended, either whether it's chemotherapy, immunotherapy, radiation, surgery. If you're omitting all of it or some of it, would be considered alternative, whereas complementary is really more in addition to. So I just wanted to make sure we understood the definitions of this as well. There's a lot of misinformation out there, right? I think that I do want to spend a little time on this because, if you open any social media anytime or the news or anything, you're going to see a lot of information out there that's very difficult to elucidate, to figure out what's fact and what's fiction, especially with just the news cycle these days. It's very hard to tell sometimes. I mean, not making any judgments specifically, just saying that it's sometimes very hard to separate fact from fiction in almost anything these days, right? So I think when someone tells you something in a very convincing way, it's hard to know what is that coming from. So ask those questions, no matter who it is, even if it's your physicians who are telling you something. Ask the questions that are making you wonder, is this true, right? How do you know this is true? How sure are you about this, right? We can explain that to you as best as we can. Other people should be able to explain this too, right? If they're writing, just because someone wrote a book about something doesn't mean that that's true, right? Just because something's in the mainstream news versus some alternative source, that doesn't mean it's true or false either. So but it's very difficult to distinguish sometimes, and we'll try to help you through that. And don't be shy about bringing something up that you've read about. Even if you feel like it will sound silly to you or your family or to us, we want to hear about it because that's something that we can help you sort through it.
If it's on TikTok, it's probably. I think we're at the time. I just want to give one last plug to research. There's been a lot of talk about research being cut. There's been 40% NIH cuts, and people don't commonly realize how good we are at research in the United States. We not only have the most Nobel Prizes in medicine, we have more than 3 times more than second place. That fuels the economy. Every dollar the NIH spends brings $2 back to the United States. And we get early access to drugs and new devices. And so I really do believe research is the best way to turn hope into miracles. So thank you guys for coming. I don't know if
So I'll just say 2 last comments and then we can break for the evening. I wanted to first thank all of the speakers and panelists and people who helped organize this, Emily and Renee, and all the other team members who are in the audience who are here, as Dan pointed out. Thank you for doing that. We have such an incredible team, and I love, this is selfish, but I love this session that we do because it brings us all together and it reminds me again, I know this every day, but it reminds me even more how amazing our team is. And I am so proud of everybody and to be part of this. So that's the first comment. The second is to thank all of our patients and families. We are all here because of all of you. And again, it's so amazing to see you all here in person, and hello to everybody who's watching this later on, you as well. Thank you for listening. And again, thank you for being here and for your interest. And again, we're here for you. So come up and talk to us afterwards. Find us in clinic when you have questions. And I think that's it. Any last comments for anyone else? Okay. Thank you so much again.